So in this video, I'm just going to be talking a little bit about the desensitization phase of eye movement desensitization and reprocessing, commonly called EMDR. So the desensitization phase is the fourth phase of a typical course of EMDR treatment. And it's probably the one that when people think about EMDR, that they associate the most with it. So typically this is the phase where there will be some form of bilateral stimulation, either in the form of eye movements or kind of little buzzers or auditory kind of stimulation. So the desensitization phase, it follows the initial phase, which is all about history taking, case conceptualization. The second phase is about resource installation. And the third phase is what we call assessment, which is a little bit different to the typical clinical assessment. What it's all about there is actually lighting up a memory network, the actual part of the memory network where the trauma is held. And in that assessment phase, we would typically look at the image that represents the most distressing part of the event. We'll take like a still snapshot of that and hold that in the mind. We will then also identify a negative cognition. This is a typically quite a rigid and quite strongly held negative belief about ourselves that comes to mind when we think of that event. We will identify a positive cognition, something there that is a little bit more balanced, a little bit more adaptive, that perhaps we might move towards once we complete the desensitization phase. We will test out what we call the validity of cognition, which is just a 1 to 7 scale in which we kind of think about how true that positive cognition is when we focus on that particular memory. We then talk a little bit about the emotion or emotions that are experienced when we focus on that event. We identify the subjective units of distress, which we call SUDS, and then we locate that in the body as well. So one of the popular texts within the trauma literature is The Body Keeps Score, and one of the really hard things to come out, certainly modern trauma-focused psychotherapy, is this idea there that the body does hold on to a large part of the trauma. It's not just an image that we've got in our head, it's not just the emotion that we experience, but there is actually a record of a traumatic event that's held within the central nervous system. That is also a target for us to work with when we're doing EMDR. So once we have worked through those first three phases, we then begin work on the desensitization phase. So in desensitization, effectively that means where we are going to actually start work on that memory network where the trauma is held. And we will go through a series of steps where we are kind of just allowing some of that emotional power to just come out of that memory itself. So as it says, we are desensitizing to the trauma event. So what that looks like in practice is once we have assessed in the way I've just described, once that memory is kind of lit up for us, we will then start some form of our bilateral stimulation. Now, it's also important when we do start our desensitization phase because of the way trauma can present, because it is imminently frightening for people because it can come with a lot of emotions that can be overwhelming. Commonly, we might start with a little bit of resource installation before we go into the actual desensitization itself. So all this is about really is that some of the resources that we work on in phase 2 of the EMDR treatment, some of the kind of interventions there which focus on developing feelings of safety or a sense of control with regards to our trauma symptoms. We just want to make sure that our clients have that available to them and they feel resourced enough to dip into the trauma memory. So sometimes we might dip into that just before we start a desensitization session. When we light it up, we've got our assessments, we've got that memory network there, and then we will start the desensitization itself. So commonly, EMDR was developed initially using eye movements. That's kind of what it is most known for. But also these days, we will use other stimuli to basically tax the two parts, the left and right hemispheres of the brain, while we sit with that emotion, we sit with that imagery, and then we just allow the mind just to work through it. So We will initially do it for, once that memory is lit up, we'll do a set of desensitization, and usually we'll do it for around 24 sets, basically. So just either doing eye movements, or in my case, I commonly use these little buzzers. And what we do with these, we've got the little lights on sides there, so we can use that for eye movement sensitization. What we can also do is just hold it and just use that as a form of basically kinesthetic stimulation. And again, it has the same effect basically. There's some evidence to suggest that the eye movements are more efficient, but actually the kinesthetic stuff, the vibrations work just as well. When I've had EMDR myself, I struggle a little bit with the eye movements. I struggle to kind of move my eyes from side to side. And as a consequence, I do prefer using the actual buzzers and close my eyes a little bit, and I can just allow my mind to do the work that I need to do to process the trauma. Also, sometimes we might just use headphones, so just having the headphones resting easily on the ears. So obviously, you can hear the guidance of your therapist. You can always kind of feedback. So you're actually in the room, you're processing the memory, but we've got that auditory and the bilateral stimulation always working for you as well. And once we've done our first set of typically 24 sets of bilateral stimulation, we will take a little pause. We will encourage you just to take a nice gentle breath all the way down into the belly and just blank your mind out for a second. And then we will say, when you think about that memory right now, what do you get? And EMDR is based on this model which we call adaptive information processing. So what it kind of talks about is the idea there that the mind knows how to get to a point of homeostasis and balance when it is dealing with difficult events. And PTSD and complex trauma presentations, when memories don't get fully processed and fully integrated, and they remain kind of fresh, they remain active, unprocessed. It's got a certain quality as though they are affecting us in the here and now. The threat is in the here and now, and we struggle really to recognise that the danger is past, it's no longer here, etc. And when we are doing this adaptive information process, as we start to desensitize, and your therapist says, "What do you get now?" Typically, we might see a little reduction in the distress, or if we don't get that straight away, we might get another little bit of information, another part of the memory, or some other aspect there of trauma memory that we just kind of just make a little note of. We see where your mind is going. As I said, your mind knows how to heal this trauma, and we notice that, we acknowledge it, and then your therapist will just give a nice little instruction just saying, go with that. And then we do the process again. And what we do is we just follow this process again, again, again. The whole time we're just kind of coming back and seeing if there is new adaptive information coming up, new ways of relating to the trauma memory itself, or whether it's starting to come down in terms of stress. And we kind of follow that process until we reach a point where there is either we've got two positives, two positive bits of information, or two neutral bits of information come up, or if we kind of feel that we've totally gone a little bit away from the trauma itself. Ideally, if we're doing what we call EMDR with a big R, therapist stays out the way. Yes, we just let the process go all the way until we reach those kind of more neutral. There are kind of EMD kind of thing, which is where we're just really focusing on desensitization to the trauma memory, not really kind of allowing the mind to go too far with generating too much adaptive information. And we just do that when we move into the next phase, which is called installation. So depending upon how you've contracted with your therapist on typically how many sessions we've got, how you would like to use those sessions. We might be really targeted just on pure desensitization of that one memory, or we might just be a little bit looser and just say, okay, well, what you get, and just allow your mind just to generate kind of broader meaning in relation to that trauma memory. Once we do get to that point where there is either, as I said, either two positives or two neutrals, we'll say, okay, notice that, and then we return to our target. We return to our target memory, we will light it up, and again, we will ask the question on a 0 to 10 scale, as you think about that event right now, what is your current level of disturbance. And again, we'll rate that on a 0 to 10 scale, and we just repeat that process. So it's kind of, we revisit it, follow through with the desensitization phase, the bilateral stimulation, and we keep doing it until ideally we reach a 0 in terms of those subjective units of stress, or if there is a valid reason as to why we're never going to get to 0, until we reach a 1. And as we work through this process, the whole idea is we're just taking some of the wind out of the sails of that particular trauma. We might not always get to the end of successful desensitization in one typical session. So we might just get to the point where, we might reduce it a little bit. We might just get it maybe down to 3 or a 4. And in that case, all it means is just that we close it as what we call an incomplete session. So we'll make a little note as to where we got to. We'll make a little note as to what our subjective units of stress are. And then we will just work through, again, one of our resource exercises, something like the safe place exercise or the container exercise, just as a way there of kind of closing that session in a really safe and resourced way, so that you as a client then can choose to move forward with the rest of your day without these symptoms being as problematic and as in your face as they might feel when you're doing the actual trauma process in session. Once we are successful in getting to that 0 or 1 with regards to the subjective units of distress, once we feel that there's no adaptive information just coming up for us, we will then make that decision to say, okay, we feel fully desensitized, and then we'll move on to the next phase of the EMDR protocol, which is what we call installation. I'm not going to go through the full process of installation here, but what it is effectively is about mapping on that new positive, balanced cognition, which enables us to view the trauma event in a more adaptive way. So I'm going to cover that in the next EMDR video that I'm going to do. If you're interested, subscribe, check it out, and follow me for some more of my other videos. If you found this video interesting, that is fantastic. If you would like to get in touch with me at my website, www.accesscbt.co.uk, if you're interested in trying out EMDR or just getting in touch anyway, by all means do so. And I look forward to seeing you there, and I look forward to seeing you on some more of my videos moving forward. And thanks for watching.